told your friend you're not okay, and tell me what's wrong and why you never said you felt that way. And guess you're trying to stay strong and fake a smile until I look away. But I've known you too long, it hurts to watch your blue eyes fade to gray as you fade away, as you fade away.
Yeah, I'm about to fade away, cause every time I wake up I feel like it's Monday. Something's going wrong with all the chemicals up in my brain. All of a sudden I don't look at anything the same way. Gotta build up of my thoughts sitting in an ashtray. I'm sorry that I'm so inconvenient, okay. Just let me be me and I'll stay out of your way. I can see the way you look at me, I'm such a disgrace. I never really asked to be brought into this place. You wanna love me? Well then baby I have a taste. All the highs and the lows, no you'll never be the same. I don't really wanna hurt you but I can't control the pain. If you're sticking by my side maybe we could be okay. Okay, maybe you could be the change I need today. I promise that I've never felt this way. I really hope that you will choose to stay through all the pain.
I know you told your friend you're not okay, and tell me what's wrong and why you never said you felt that way. And guess you're trying to stay strong and fake a smile until I look away. But I've known you too long, it hurts to watch your blue eyes fade to gray as you fade away, as you fade away, as you fade away.
Like nothing I felt, my mind overwhelmed. I think that I'm broken but I hope you can't help. I know I'm not perfect, but some days I feel far more worthless. Baby, you make me feel nervous. If I still have you, I have purpose. It's all worth it.
I know you told your friend you're not okay, and tell me what's wrong and why you never said you felt that way. I guess you're trying to stay strong and fake a smile until I look away. But I've known you too long, it hurts to watch your blue eyes fade to gray as you fade away, as you fade away, as you fade away. Tell me what's wrong and why you never said you felt that way. And guess you're trying to stay strong and fake a smile until I look away. But I've known you too long, it hurts to watch your blue eyes fade to gray.
The patient is positioned supine. Tilt the head back on the C1 joint while keeping the mouth closed. The head should remain in the neutral position. The chin lift elevates and anteriorly displaces the hyoid bone away from the pharyngeal wall. Open the mouth slightly. Depress the mandible with thumbs. Grip the mandibular rami with your fingers and lift the mandibular teeth over and in front of maxillary teeth. This is a two-handed technique. Patient positioning should be supine or lateral. Open the patient's mouth. Place the tongue blade at the base of the tongue. Draw the tongue anteriorly to lift it off the pharynx. Place the airway in the mouth with the concave side facing down, so that the distal end is approximating but not touching the posterior wall of the oropharynx. The flange and 1 to 2 centimeters of the shaft of the airway should protrude above the incisors. Perform the jaw thrust maneuver to lift the tongue off the pharyngeal wall. Now tap the airway down the last 2 centimeters so that the curve lies beyond the base of the tongue. Anesthesia is administered when placing the nasal airway device. The patency of the nares should be gauged by inspection and the mirror test, condensation. A topical slurry composed of 10 milligrams phenylephrine in 10 milliliters of 2% lidocaine jelly is applied. This provides anesthesia and vasoconstriction of the nasal airway. The lidocaine jelly mixture is swabbed just inside the external edge of nares until local anesthesia occurs. Gently place successive swabs deeper into nares until 3 swabs can comfortably be placed simultaneously to the level of the posterior nasal wall. If 3 cotton swabs can be accommodated, then a 7.5 millimeter airway will pass. If swabs are not available, then the lidocaine slurry can be applied via a syringe directly into the nose. The patient positioning may be supine, lateral, or sitting. Pass the airway gently into the nose with the concave side facing the hard palate. If resistance is met in the posterior pharynx, bend the tube 60 to 90 degrees with gentle pressure and proceed down the pharynx. If the airway will not pass with moderate pressure, it may be helpful to rotate the airway 90 degrees counterclockwise and then rotate it back to the original position as it makes the bend down the pharynx. If the airway still does not pass, a narrower tube should be used. Once inserted, withdraw the tube 2 centimeters and pass a small suction catheter through it. Push the airway forward using the catheter as a guide. If it is still unsuccessful, the nair can be redilated or the other nair can be prepared. Positioning should be supine. Place an oral or nasal airway. Hold the mask in the left hand. With the thumb and index finger, grip the mask around the rim of the mask with the body of the mask fitting into the left palm. Place the narrow end of the mask over the nose. Avoid pressure on the eyes. Lower the body of the mask to the face so the chin section of the mask rests on the alveolar ridge. Seal the contact areas with the midsection of the face by pulling the mandible up into the mask with the curled fingers of the left hand. Then deliver intermittent breaths with the right hand on the ambu bag. In a spontaneously breathing patient, time the delivered breaths to coincide with the patient's inhalations. In the tachypnic patient, alternate the assisted breaths with spontaneous respirations. Buccal gauze sponges can be placed in the cheeks of an edentulous patient to improve fit to the face. If the patient is already horizontal and unconscious, or if oral intubation is planned, the patient's position should be supine with the head in the sniffing position. If the patient cannot tolerate lying flat, the patient may remain sitting for blind nasal intubation. Check the endotracheal tube cuff for leaks by inflating and deflating the balloon with 10 milliliters of air. Check the laryngoscope to ensure the light is functioning. Pre-oxygenate the patient with bag mask ventilation. Have an assistant apply cricoid pressure using the Selleck maneuver. Remove the oral airway. Grasp the laryngoscope in the left hand. Instruct the awake patient to open the mouth as widely as possible. In the unconscious patient, place the thumb and second fingers of the right hand on the right upper and lower molars and open the mouth with a scissor-like motion. Gently place the laryngoscope blade in the right side of the mouth, taking care to avoid damaging the teeth. Sweep the tongue to one side of the oral cavity while advancing the laryngoscope blade toward the glottis. Position the end of the blade under the epiglottis or in the vallecula, depending on the type of blade used. Avoid cocking the left wrist backward and levering the blade on the teeth. Lift the laryngoscope handle straight up till the vocal cords are visualized. Pass the styleted tube with the cuff deflated into the right side of the mouth and through the vocal cords. Remove the stylet as the cuff passes through the vocal cords. Then place the endotracheal tube so that the cuff is just distal to the cords and cannot be seen between or above the cords. Inflate the balloon with 5 to 10 milliliters of air and hold the tube firmly in place at the lips. Now, place an end-tidal CO2 monitor in the breathing circuit between the tube adapter and the ventilator bag. Gently give several breaths. Watch the chest for expansion. Check a minimum of 6 breaths for measurement of CO2 on the CO2 monitor. This is to ensure that CO2 return to the breathing circuit has a pulmonary source and is not insufflated air from the stomach. Listen for bilateral breath sounds over the chest and for an absence of sounds over the gastric area. If all clinical signs point to intubation of the trachea, the assistant may then release the cricoid. Tape the tube securely and carefully place a bite block in the awake patient to avoid obstruction of the tube from biting. Obtain a chest X-ray to check endotracheal tube placement. If more than one intubation attempt is necessary, the patient should have a 100% oxygen bag mask airway re-established between attempts. If the esophagus is intubated inadvertently, in cases where the vocal cords are difficult to visualize, it may be helpful to leave the endotracheal tube in place as a marker to avoid repeated esophageal placements. Inadequate mouth opening is the most common mistake, making laryngoscopy difficult, as well as greatly increasing the risk of damage to the teeth. Nasal intubation is generally done in the awake, spontaneously breathing patient when there is an advantage to avoiding laryngoscopy, such as with a cervical neck fracture. Check the endotracheal tube cuff for leaks by inflating and deflating the balloon with 10 milliliters of air. Coat the end and cuff of the unstyleted tube with viscous lidocaine jelly. If warm saline is available, the tube may first be soaked for 3 minutes and then the procedure is performed. Place the tube gently in the nose and advance it using the technique described for the nasal airway. Gently extend the neck if the tube is difficult to pass. Watch for signs of fogging or condensation in the tube as the tube approaches the vocal cords. The quality of the voice may also change. Ask the patient to breathe deeply and gently advance the tube through the cords while they are open during the inspiration. The patient should immediately lose phonation, inflate the cuff, verify position, and secure as for an oral endotracheal tube. The patient should be positioned supine with the neck in neutral position. In trauma patients, care must be taken to protect the spinal cord, as a cervical spine injury must be presumed until radiologic and clinical examination have excluded this diagnosis. Sterile prep and drape the anterior neck if time permits. Palpate the cricothyroid membrane below the thyroid cartilage in the midline. Stabilize the thyroid cartilage firmly with one hand and make a transverse incision approximately 2 centimeters in length down to and through the cricothyroid membrane. Insert the tracheal spreader down the distal trachea and gently spread. Alternatively, if a tracheal spreader is not available, insert the handle of the scalpel transversely through the wound into the trachea. Rotate the scalpel handle 90 degrees to enlarge the opening in the cricothyroid membrane. With the tracheal spreader in place, insert a tracheostomy tube and remove the tracheal spreader. Alternatively, a small retractor can be used if a tracheal spreader is not available. Inflate the cuff with 5 milliliters of air. Attach an ambu bag and ventilate the patient with 100% oxygen. Auscultate the chest to confirm equal and clear breath sounds bilaterally. Control superficial bleeding either with direct pressure or with hemostats and silk ligatures if necessary. Suture the tracheostomy tube to the skin with 2O-proline suture. The patient should be positioned supine with the neck in the neutral position. In trauma patients, care must be taken to maintain C-spine control. Sterile prep and drape the anterior neck if time permits. Palpate the cricothyroid membrane below the thyroid cartilage in the midline. Attach a 5 milliliter syringe to a 12 to 14 gauge angiocatheter and puncture the skin in the midline over the cricothyroid membrane. Direct the catheter inferiorly at 45 degrees to the skin. Gently advance the catheter while aspirating. Stop once air is aspirated, which confirms position within the tracheal lumen. Advance the catheter over the needle, down the distal trachea, and withdraw the needle. Attach a 3 mm pediatric endotracheal tube adapter to the hub of the catheter. Attach a Y connector to the oxygen tubing and to the pediatric endotracheal tube adapter. Maintain oxygen flow at 15 liters per minute. Provide ventilation by intermittently placing the thumb over the open end of the Y connector for 1 second and off for 4 seconds. Landmarks used for tracheotomy are the thyroid cartilage and the sternal notch. The incision is usually made approximately 2 finger breadths above the sternal notch. An incision of about 1 to 1.5 inches is made transversely. Strap muscles are separated vertically or transversely, and the tissue between them is divided. The thyroid isthmus sometimes needs to be retracted inferiorly or divided. The trachea is identified and separated from the surrounding tissues, so the 2nd to 4th tracheal rings are identified. 2 stay sutures are then placed in the trachea at the approximate level of the 2nd or 3rd tracheal ring. The patient should be positioned supine with the neck in the neutral position. In trauma patients, care must be taken to protect the spinal cord, as a cervical spine injury must be presumed until radiologic and clinical examination have excluded this diagnosis. The trachea is incised longitudinally. The opening of the trachea is then spread using a tracheal dilator. For urgent tracheostomy, a number 6 endotracheal tube or a tracheostomy tube can be used. The endotracheal tube or tracheostomy tube should initially be inserted perpendicular to the trachea to avoid placement of the tube in the pretracheal space. A number 6 endotracheal tube can be used in emergent situations for either cricothyroidotomy or tracheostomy. The endotracheal tube is inserted to a depth of 8 to 10 centimeters. Care needs to be taken not to insert the endotracheal tube too far, or unilateral bronchial intubation may occur. If a formal tracheostomy tube is used, it should be inserted to the level of the strap used to secure the tube. It is important to confirm tube position in the trachea by confirming that bilateral breath sounds can be heard in the chest. An end-tidal CO2 detector can be attached to the endotracheal tube or tracheostomy tube to confirm position in the trachea as well. It is imperative that the tube is sutured or held in place to prevent accidental dislodgement, which may be fatal.